Hello, my name is Dr. Jivianne Lee. I'm a rhinologist and endoscopic skull-base surgeon at the University of California, Los Angeles. I wanted to thank my co-editors, Dr. David Gudis and Dr. David Kennedy, for giving me the opportunity to contribute this chapter to our Rhinology Worldwide video textbook. The topic of this chapter is comprehensive management of chronic rhinosinusitis with nasal polyposis. These are more corresponding disclosures. So just to give you an outline of this chapter, first we'll start with a brief introduction, reviewing the general characteristics of CRS with nasal polyposis, including epidemiology, pathophysiology, clinical presentation, and diagnosis. And then I'll move on to discuss the vast spectrum of medical treatments that are currently available, including the recently introduced high-dose fluticasone exhalational delivery system and the steroid-eluting implants, as well as discuss the relevant evidence associated with their use. Then I'll switch gears and focus on the surgical procedures that we have available, including a full house endoscopic sinus surgery, the JAV3, as well as less invasive options like in-office polypectomy. And then we'll focus on the biologics, which have been recently introduced, particularly for refractory cases, and the relevant evidence. And then finally, I'll conclude by discussing the multidisciplinary consensus stepwise treatment algorithms that have been recently developed for comprehensive management of CRS with nasal polyps. So nasal polyps are these benign growths that arise from the lining of the nose and the sinuses. This is a nasal endoscopic picture. You can see an example of a nasal polyp here. The etiology is still unknown, but it's believed to be multifactorial and involve genetic and environmental components. It's also associated with chronic inflammation and asthma. Around a third of nasal polyp patients have concurrent asthma symptoms. It's also been associated with allergic rhinitis, although to a lesser degree than asthma. And of course, there's also the entity of AERD, or aspirin-exacerbated respiratory disease, that's characterized by nasal polyps, asthma, and an allergy to aspirin. So if we look at the epidemiology of nasal polyposis, it affects about 2 to 4% of the population. It's around 20% of all CRS patients. It is more common in men than it is in women, but there is no race predilection. Also increases with age. The typical presentations are adults over the age of 40, peak between 50 to 59 years of age, and a mean of 42. It's rare in children under the age of 10. If nasal polyps are detected at that time, then the patient would need to be worked up for cystic fibrosis. In terms of the underlying pathomechanism, it's believed that colonization and biofilm formation by bacteria and mold can result in reduced epithelial barrier function. This then leads to epithelial activation and release of cytokines and chemokines, including TSLP. Further downstream, it ends up causing the release of IL-4 and IL-13, which increases local IgE production, as well as IL-5, which results in eosinophil activation. And of course, the reason why it's important to be familiar with this Th2 inflammatory pathway is because a lot of our new therapeutic options, particularly the biologics, are designed to specifically target some of these steps along this Th2 inflammatory cascade. And then eventually, this leads to epithelial apoptosis and shedding and subsequent barrier dysfunction. So in terms of the clinical presentation, when the nasal polyps are small, usually the patients are asymptomatic, but as they increase in size, the nasal polyps end up blocking the sinus drainage pathways, and that's when we get mucus accumulation and secondary infection. So usually, the patients present with nasal obstruction and loss of smell, and then eventually, when a secondary infection develops, that's when we see discolored nasal discharge, and the patient begins to notice facial pain and pressure. So here's another nasal endoscopic picture of polyps completely filling the nasal cavity from the roof down to the nasal floor. So in terms of the diagnosis, nasal endoscopy is absolutely critical. Usually the polyps appear as these teardrop-shaped growths that are translucent. They almost look like oysters or these peeled seedless grapes. They're benign, so these are not malignant or pre-malignant lesions. So here in this nasal endoscopic photo, you can see the nasal septum here with the septal spur abutting the inferior turbinate, and then polyps here. And then again, here we see the septum medially, nasal polyps, and then the inferior turbinate laterally. Part of the diagnosis is also getting a CT scan. This helps us to define the extent of disease and identify which sinuses are affected. It's absolutely critical, particularly for analyzing the surgical anatomy and preparation for surgical interventions. So here we can see on the CT scan, there's opacification of the maxillary and the ethmoid sinuses. Usually for diagnosis, we don't require a biopsy. Unless the patient has a unilateral polypoid lesion or doesn't have the classic appearance endoscopically of nasal polyps, or the patient has some symptoms that are suspicious for malignancy. And typically at the time of sinus surgery, if the patient's a candidate, we send all the specimens to pathology as well for confirmation of the diagnosis. So moving on to the various treatment options for nasal polyps. Starting with medical therapy, topical intranasal steroids are still the first line medical treatment for nasal polyps. Mometasone and more recently, the high-dose fluticasone exhalational delivery system are the only intranasal steroids that are specifically FDA approved for nasal polyps. So here's mometasone. This is the high-dose fluticasone exhalational delivery system. We usually reserve oral steroids for patients with severe nasal polyps. You would also consider giving antihistamines in patients with underlying allergic rhinitis, or if they have concurrent infection, then the patient may need antibiotics. There has been some recent evidence that doxycycline specifically may help to reduce nasal polyp size as well. I want to spend some time talking about some of these more recent medical treatment options. So the exhalational delivery system was FDA approved for nasal polyps for delivering high-dose fluticasone back in 2018. So what's unique about this particular delivery device is that it is a closed system, which is different from our typical intranasal steroid sprays. And the way it functions is that when the patient exhales, the breath propels the spray intranasally. So you end up with this bidirectional flow. And again, this is a much higher dose of fluticasone than the typical traditional intranasal steroid spray fluticasone that we've had in the past. It's at 93 micrograms, and it's a much higher dosage on a daily administrative therapy. And when they did some distribution studies, they were able to find that this exhalational delivery system resulted in broader and deeper deposition of the medication than our traditional nasal steroid spray. So here you can see what the distribution is with the typical nasal spray. This lighted area here in orange shows you the distribution of the medication. Is particularly focused in the anterior nasal cavity and the vestibule and the inferior portion. Whereas with the exhalational delivery system, you can see that really extends all the way up to the superior aspect of the sinonasal cavity and then posteriorly as well. So if we look at the evidence to support this therapy, there have been 2 double-blinded randomized controlled trials that encompass 645 CRS with nasal polyp patients. These patients were randomized to receive either a placebo or the exhalational delivery system high-dose fluticasone. And after 24 weeks, they're able to show a significant reduction in nasal polyp grade, nasal congestion, that's the orange line here, rhinorrhea, facial pain and pressure, and sense of smell in the treatment arm versus a placebo, which is this blue line here. I also wanted to mention the in-office steroid-eluting ethmoid implant. It is also a form of medical therapy, but it does require placement under topical or local anesthesia. So this is usually an in-office procedure. So this is an 8-pronged implant that has increased radial strength compared to some of the spring implants that we actually use at the time of surgery. It releases 1350 micrograms of mometasone over 90 days and is specifically designed to treat recurrent nasal polyps within the ethmoid cavity. So here's what it looks like pre-implant at day 0, and then immediately post-implantation when it's placed into the ethmoid bed. And you can see that by day 30, the polyps have begun to recede in size, and by day 90, the ethmoid cavity is completely clear, an outcome that was sustained over the course of 6 months in this particular case. So here is a video of a steroid-eluting ethmoid implant that I placed under local anesthesia. So you can see it does have a wide diameter and rather stiff composition. So sometimes I do inject the septum, the lateral nasal wall, just depending on patient comfort. As you go back more posteriorly, though, all of these patients have had previous sinus surgery. So there's ample space to place the implant. It's important to position it just right so that's completely embedded within the polyps, and all of the surfaces of the implant that's eluting the steroid are contacting the polypoid tissue that you're trying to treat. And so this is what it looks like immediately post-implantation. And this is very well tolerated by patients, again, just under local anesthesia. So if you look at the evidence for use of the steroid-eluting sinus implants, there was a double-blinded randomized control trial that looked at 300 nasal polyp patients who were deemed candidates for revision endoscopic sinus surgery. They were randomized to receive either a sham procedure or the implant. And what they were able to show was that by day 90, there was a significant reduction in nasal obstruction and congestion scores, polyp grade, and ethmoid sinus obstruction in the implant versus the control group. So then the orange line is the treatment arm, and the blue line is the sham arm. And all of them received a background therapy of mometasone furoate as intranasal steroid in addition to the sinus implant. So typically, the treatment protocol for primary nasal polyposis, at least prior to the advent of biologics, was to start with topical nasal steroids, so mometasone, or more recently now, the high-dose fluticasone exhalational delivery system. If that failed, then we could move on and give a burst of oral steroids. And then if the patient continued to have symptoms, then we would move on to do endoscopic sinus surgery. If there is underlying allergies, then we also consider adding antihistamines or leukotriene modifiers. And if the patient had concurrent infection, then we also may consider giving antibiotic therapy. So typically, the type of surgery that we would do is, again, it's endoscopic sinus surgery, but the specific extent is actually called a full house. So what that means is that all of the 8 sinuses, their ostia are opened as widely as possible, not only to remove the nasal polyps, but to try and optimize the distribution of our postoperative topical therapies, especially steroid irrigations. So here's a typical example. You can see the patient with nasal polyps. You use a series of grasping instruments or what we call shavers or microbeaters to debride the polyps, identify all of the sinus ostia, widen them as much as possible. And then, at the end of the case, then you can see these nicely patent sinus cavities. When we looked at our surgical outcomes, what's been reported in the literature, the recurrence rate was actually anywhere from 4 to 60%, with a median of 20%. And in patients with comorbidities like asthma and aspirin sensitivity, it could be as high as 60 to 90% with this traditional full house endoscopic sinus surgery. And there were various factors that could be associated with increased recurrence, including these so-called type 2 comorbidities. So when we started counseling our patients, we informed them that endoscopic sinus surgery is really just the first step in a multi-step process and treatment of this disease long-term, that this is a chronic condition that really requires continued medical therapy in order to maintain control of the nasal polyps and minimize recurrence. So we always emphasize the importance of compliance. And I also highlight the fact that CRS with nasal polyps, again, is a long-term condition that requires regular surveillance. So usually this involves serial nasal endoscopy, continuing medical therapy, whether this be saline rinses, topical steroids, irrigations, treating any exacerbations, potentially with oral steroids, managing any comorbid disease, or revision endoscopic sinus surgery, or potentially some other in-office procedures in order to maintain that lawn and make sure it's nicely well manicured and prevent those weeds, or in this case, nasal polyps, from growing back. So the traditional treatment protocol for recurrent nasal polyps was topical nasal steroids or off-label steroid irrigations. If that failed, you can see it's very similar to primary nasal polyposis treatment protocols. We would move on to oral steroids. If that failed, you can continue this laundry list of medical therapy or move on again to revision endoscopic sinus surgery. So I wanted to mention some recent advances in surgical treatments, both from a less invasive approach where it can be done in the in-office setting, similar to the steroid-eluting implant, which is really a combined medical and surgical procedure that's done under local anesthesia, as well as the other end of the spectrum where we can do more extensive surgery than the full house endoscopic sinus surgery that I just described. So one of the more recent procedures is doing an in-office polypectomy, again, under local anesthesia. There's a whole host of different devices and shavers that have been designed specifically for the in-office setting or to be done in the clinic. This was a study that came out of Canada, which looked at 68 patients with primarily nasal and ethmoid polyps. Almost 90% had successfully completed in-office polypectomy. It only took about 3 minutes per side. So only a very small proportion that underwent incomplete resection because the polyps were fibrous. This was using a vacuum power type shaver. They reported that the comfort level was 97%. In 90% of cases, the bleeding was considered to be light, and there was a significant reduction in nasal obstruction as well as polyp grade with no complications. So just to give you an example of what this procedure entails, this was a case of a 63-year-old gentleman who had had 2 prior sinus surgeries, now with recurrent polyps, and he declined to undergo revision endoscopic sinus surgery in the operating room, so I thought I would go ahead and try to remove the polyps in the clinic setting. So this is a shaver microderbrator that we use, which can be placed underneath the nasal polyps. And as long as you're very careful not to touch the mucosa along the lateral nasal wall and the septum, this can be very well tolerated by patients since the polyps are non-sensate. And there's very minimal bleeding. You can see a nice clear ethmoid cavity at the end of the procedure. And I think one of the most satisfying aspects of doing this type of polypectomy in the office setting is that the patient experiences immediate relief as soon as they finish with the procedure. Another technologic innovation on the surgical side in the clinic setting is an in-office image guidance system or a navigation, which allows us to map exactly what we see endoscopically to the CT scan. Nowadays, some of these navigation systems are so compact, they can really fit into just a shelf of any endoscopy tower. We can also navigate malleable instruments, which can be very useful for in-office polypectomy. So here was a case of a 58-year-old gentleman who had had multiple sinus surgeries, now with recurrent polyps here, filling the frontal sinus. You can see that it's pulsating. So I decided to go ahead and use in-office navigation. Mainly because I hadn't done any of his prior sinus surgeries, and to ensure that when I proceeded with a polypectomy that I'd be in the correct location. So this is a malleable seeker, which you can navigate. You can match the endoscopic picture to the CT scan. You can see the green hatch marks, which tell you where the tip of the instrument is on the imaging. And so once I confirmed that I was in the frontal sinus, or anticipated based on the nasal endoscopic view, then I felt comfortable proceeding with the in-office polypectomy. Here I'm using grasping forceps, we call giraffes, to remove the polyps within the frontal sinuses, and then a curved shaver or microdermabrator to breed more of the polyps, and then placement of a steroid-eluting spring implant to treat some of the residual polypoid inflammation. Then on the opposite end of the spectrum, so those were the less invasive procedures that can be done under local anesthesia. More recently, the draft 3 procedure, which is a more extended form of endoscopic sinus surgery, has been recommended for recurrent nasal polyp patients. So the draft 3 procedure has various names, but essentially it involves removal of the floor of the frontal sinus, the inner sinus septum, and the superior nasal septum to create a common frontal sinus drainage pathway. It's also known as the modified endoscopic Lothrop, the transeptal frontal sinusotomy, or the frontal sinus drill out. So here's an endoscopic view of the draft 3. So again, involves removal of the inner sinus septum, the superior nasal septum, and then the floor of the frontal sinus so that both frontal sinuses, which you see here, drain into a common drainage pathway. So recently, there was a study that came from Professor Wormald out of Australia. It was a retrospective review of 300 nasal polyp patients. And what they found was that the revision surgical rate for patients undergoing like a traditional full house endoscopic sinus surgery or draft 2A was almost 40% versus 7% for this draft 3 procedure that I just described. And so their conclusion was that the draft 3 significantly reduced the risk of nasal polyp recurrence in patients with asthma and aspirin sensitivity. And the rationale was that by making a larger hole essentially and a bigger frontal sinus drainage pathway, it helped to optimize the distribution of the topical therapies. And recently, I've been using the draft 3 for a lot of these refractory nasal polyp patients. So just to give you an example, here was a case of a 54-year-old male who had had multiple sinus surgeries for nasal polyps over the last couple of decades. His past medical history was significant for asthma, but there was no history of aspirin sensitivity. He presented with rhinorrhea, anosmia, and nasal obstruction for several months, despite being on budesonide irrigations, antibiotics, and multiple courses of prednisone. And he was actually self-medicating with the oral steroids whenever his symptoms got too severe. Here's what the nasal endoscopy looked like. You can see polyps filling the nasal cavities on both sides. On the imaging, you could see that for the most part, the maxillary sinuses or lower sinuses are actually clear. Most of the disease is concentrated in the superior ethmoid cavity and the frontal sinuses, which isn't too uncommon because again, our topical steroid irrigations are usually more effective than dependent sinuses in the superior aspects of the sinonasal cavity. So the patient decided to proceed with revision endoscopic sinus surgery. So I started out by doing a full house ESS. You can use various forceps and microbreeders to remove the polyps. Remove them in all 8 sinuses, widen the sinus ostia as much as possible. But this time, when I encountered the area of the frontal sinus, I decided to do the draft 3 approach. I find myself doing a hybrid technique. So usually identify the frontal ostium with an angled endoscope, and then place a drill into the ostium and then drill anteriorly through the nasal frontal beak. You just have to be careful as you're doing this that there's an adequate AP diameter of the frontal ostium so you don't risk injuring the skull base posteriorly. You then remove the intervening bone between the 2 ostia. And then usually I come back anteriorly then This is the outside-in approach that was developed by Richard Harvey, where you can make a mucosal incision in the superior nasal cavity down to the superior septum, and then use a suction freer to elevate the mucosa posteriorly until you reach the first olfactory neuron, or alternatively, you can just use a suction bogey to ablate this mucosa, since it will be removed through the course of the drill out, and then use a series of drills to drill the bone laterally until you reach the nasal skin anteriorly and the medial orbital wall posteriorly. You then do the same on the contralateral side. And then once you identify the lateral limits of the dissection or the drill out, then you remove the intervening bone and the floor of the frontal sinus until you reach the mucosa. And then usually I do like to identify the frontal ostia posteriorly, so I have some idea of how far I'm going to need to drill. And then this is what it looks like at the end of the procedure. You can see both frontal sinuses nicely patent, draining out to a common frontal sinus drainage pathway. And recently, there have been some studies to support this concept that the larger draft 3 surgery helps to optimize the distribution of our topical therapies. This was a cadaveric study that used a computational fluid dynamics model to assess, again, the distribution of sinus irrigations before and after surgery. So these videos are courtesy of Dr. John Craig out of Henry Ford. So this is what the preoperative distribution looks like. You can see that there's really no penetration at all up into the frontal sinuses, which is here. This is a sagittal view. This is anterior, this is posterior, just to get you oriented. And then postoperatively, with like a full house endoscopic sinus surgery, here you can see that there is some distribution to the inferior aspect of the frontal sinuses. Now, if you contrast that, though, with the draft 3, so in this cadaveric study, you can see after the draft 3, there's rapid filling of the saline that's been infused with blue dye. And then here with this CFD model, now after the draft 3, you can see how the irrigations do penetrate all the way up to the superior and lateral aspects of the frontal sinus cavities. So this was a study that was published in the official journal of the American Academy of Otolaryngology Head and Neck Surgery. And it looked at the impact of early versus delayed endoscopic sinus surgery in CRS patients with and without nasal polyps and their impact on healthcare utilization. The reason why I wanted to include this study is because it did have some influence in development of these stepwise algorithms in management of nasal polyp patients. So this was a retrospective market scan database analysis that compared the number of visits and prescriptions of CRS patients, and they were categorized according to the time of first diagnosis of their nasal polyps and when they actually underwent surgical intervention. So in group 1, these were patients where the interval between the time of diagnosis and surgery was less than a year versus group 6, where the patients took more than 5 years between the time of diagnosis and when they actually had surgical intervention. And what they were able to show was that there was a statistically significant increase in healthcare utilization in the group 6 patients. So those patients where there was a longer time interval between the time of diagnosis and surgery versus the group 1 patients. And that extended to the number of visits, the number of prescriptions throughout this entire time period. So now we've discussed, the first line medical treatments for CRS with nasal polyps, some of the recent innovations like the steroid-eluting implant, the exhalational delivery system. Also gone over some of the surgical interventions and the more recently developed in-office procedures. So now I wanted to move on to summarize the biologics. So we have anti-IgE, which is omalizumab. We also have the anti-IL-5 biologics, mepolizumab, reslizumab, and benralizumab, which is an antibody against the IL-5 receptor. And of course, we also have dupilumab, which is an antibody against the IL-4 and IL-13 receptor. And then these are the 3 biologics that are currently FDA approved for CRS with nasal polyposis. So omalizumab, mepolizumab, and dupilumab. And all of these different biologics, as I mentioned at the very beginning of this presentation, target specific pathways along this Th2 inflammatory cascade. And this is all part of this concept of precision medicine and endotype driven treatment of chronic upper airway diseases. So starting with omalizumab, and this is an antibody against IgE. It binds a circulating IgE, which inhibits binding of IgE to the IgE receptor. This then in turn reduces free IgE levels and downregulates the IgE receptors on mast cells and basophils. So if we look at the evidence, recently I had to do a state-of-the-art review for the official journal of our American Academy of Otolaryngology Head and Neck Surgery. And one of the original pilot studies came from Professor Javert, where they did a randomized double-blinded placebo-controlled trial. It was a small study where 16 patients received omalizumab, whereas only 8 were given placebo, and they were able to show significant reduction in total endoscopic polyp score after 16 weeks in the treatment arm versus placebo. And then, of course, more recently, we have the 2 randomized phase 3 trials with a much larger cohort, where they were able to demonstrate significant improvement in nasal polyp score, nasal congestion score, and disease-related quality of life after 24 weeks in the treatment arm versus placebo. And then we have the biologics that target IL-5. So if you recall, IL-5 is important for eosinophil maturation, activation, and trafficking. So mepolizumab and resolizumab are antibodies against IL-5, whereas benralizumab is an antibody against the IL-5 receptor. So if we take a look at some of the trials, one of the pilot studies showed a significant reduction in nasal polyp score in the treatment arm and greater improvement in CT findings in 30 nasal polyp patients that were randomized to either receive MEPO or placebo. Then there was a larger study from Professor Bacher, who looked at 105 nasal polyp patients that were treated with either MEPO or placebo, and they're able to demonstrate a greater reduction in the need for surgery at week 25, as well as improvements in quality of life, nasal polyp, and symptom scores versus placebo. And then more recently, this was just published in Lancet this past year. This was the large phase 3 trial. It encompassed 93 centers, 11 countries, where 206 patients received MEPO versus 201 placebo, and they're able to show significant improvement in nasal polyp score and nasal obstruction in the treatment arm versus placebo out to 52 weeks. And then we also have IL-4 and IL-13, which are important for promoting B-class switching and increasing IgE production, as well as stimulating eosinophil tissue trafficking. Dupilumab is an antibody against the IL-4 and IL-13 receptor. And if we look at the evidence, there have been the landmark Liberty trials. This was also from Professor Bacher, where they looked at 448 adult patients with nasal polyps randomized to receive either dupilumab versus placebo. And they're able to show significant reduction in polyp size, sinus opacification, and symptom severity up to 52 weeks in the treatment arm versus controls. So putting all of these different treatments together, there have been multiple consensus statements discussing where these different types of therapeutic innovations should fit into the algorithm for management of our nasal polyp patients. So this was the international consensus statement on allergy and rhinology that was originally published in 2016, updated in 2021, and I had the privilege of being a part of this latest publication. This is a systematic review of the literature that covered over 144 topics dealing with allergy and rhinosinusitis, where the literature and the evidence is graded and recommendations are made. And there is a specific section that deals with nasal polyps and looks at these various treatment options and what the recommendations should be based on the literature and the evidence that's been published. So if we look at each of these treatment options, what's been specifically recommended are topical intranasal steroids that has very strong evidence to support its use in patients with nasal polyps, oral steroids, but only on a short-term basis, and aspirin desensitization for patients with AERD. The treatments or recommendations or against their use included antifungals, intravenous antibiotics, topical antibiotics, and non-macrolide antibiotics, unless the patient has an acute exacerbation. And then these treatments here were considered options. So that includes saline, whether it's delivered as a spray, a rinse, or a nebulizer, non-standard topical nasal steroids. So that includes budesonide rinses and the exhalational delivery system, macrolide antibiotics, and anti-leukotrienes. And that's all summarized here as well. They also more recently included the steroid-eluting implants, and that was considered to be an option for patients with nasal polyps. So with respect to the biologics, the ICAR consensus was that dupilumab is recommended for patients with severe CRS with nasal polyps, particularly in patients who have not improved despite other medical and surgical treatment options. Omalizumab was considered an option to weak recommendation for severe CRS with nasal polyposis, especially in patients with concurrent poorly controlled allergic asthma. And then finally, mepolizumab was also considered an option for patients with severe CRS with nasal polyposis and comorbid asthma. Another consensus statement, which was unique in that it's multidisciplinary, is the one that was published from Euphoria that specifically looked at the role of biologics and their indications. Just to clarify, Euphoria is a European Forum for Research and Education in Allergy and Airway Diseases. They organized a multidisciplinary expert board meeting in Brussels back in November of 2018. So before any of the biologics were actually FDA approved in the United States. And what was really unique about this particular board meeting or consensus statement was that it was comprised of rhinologists, pulmonologists, and allergists. There was also a patient there who had AERD. So there was a patient advisory board meeting that was held immediately after the multidisciplinary expert board meeting. And during that session, all of the available evidence at that time were reviewed for the biologics, and the goal was to determine their role in patients with CRS with nasal polyposis, with and without asthma. And it was based on expert opinion. There was no specific Delphi survey, and it was patterned after some of the pulmonary indications. So here was the picture of that Euphoria multidisciplinary expert board meeting. It was chaired by Wiske Falkens from the Netherlands and Valerie Lund from the UK. Peter Hellings was the leader who organized this meeting, and myself, Stella Lee, Brent Sr., and Joe Hahn, we were fortunate enough to have the privilege of representing the American contingent on the rhinology side. And so this is what the consensus was for Europe. The indications for biologics in patients with nasal polyps. So the patients would have to have bilateral nasal polyps. If they had a history of surgery, they would need to meet 3 of the listed criteria here. So evidence of type 2 inflammation, need for systemic steroids in the last 2 years, significant impairment in quality of life and loss of smell, and then diagnosis of comorbid asthma. And then if there was no history of surgery, then they would need to meet 4 of the 5 criteria. Then more recently, the EPOS document actually designated certain cutoff points to specify and clarify what these different parameters would require. So for evidence of type 2 inflammation, that would mean having tissue eosinophils greater than 10 per high power field, or blood EOs greater than or equal to 250, or total IgE greater than or equal to 100. For systemic steroids in the last 2 years, They recommended having at least 2 courses per year or long-term low-dose steroids of greater than 3 months. For quality of life, they used the SNOT-22, which is the validated quality of life instrument. They wanted a score of greater than 40. And then for loss of smell, there would have to be anosmic on the smell test. And then in terms of comorbid asthma, they specified that the asthma would require regular inhaled corticosteroids. And as part of that Euphoria multidisciplinary expert board meeting, we also aim to define response to biologics in our nasal polyp patients. So essentially, we use the same 5 criteria, except turned it around to see if there was any improvement. So that would include reduced nasal polyp size, reduced need for systemic steroids, improved quality of life and sense of smell, and then reduced impact of comorbidities. The patient would then need to be evaluated for a treatment response after 16 weeks, and that was based on all the original clinical trials. And if there is no response to any of the criteria after 16 weeks, then the consensus was that treatment with that biologic should be discontinued. If the patient has some response, then the treatment would be reevaluated after 1 year. So an excellent response was defined as meeting 5 criteria, moderate response 3 to 4 criteria, poor response 1 to 2 criteria, and then no response 0 criteria. So we wanted to do something similar for the United States and not just focus specifically on the biologics, but review the entire complement and spectrum of treatment options that we currently have available for CRS with nasal polyposis. So to that end, we convened a multidisciplinary expert panel that met at Rhino World in Chicago in July of 2019. The panel was comprised of rhinologists and allergists, so a total of 11 panelists that were active members of the American Rhinologic Society, the American Academy of Otolaryngologic Allergy, the American Academy of Otolaryngology Head and Neck Surgery, the American College of Asthma and Immunology, and the American Academy of Allergy, Asthma, and Immunology, or the Quad AI. And specifically, the panelists were Joseph Hahn, John Basso, Sung Cho, Christine Franzese, Kent Lamb, Andrew Lane, Stella Lee, Jim Palmer, Andrew Peters, Zach Soler, and myself. And our goal was to review the available evidence for all FDA-approved treatments of nasal polyposis in order to develop a multidisciplinary consensus on a stepwise treatment algorithm for management of this disease. And I wanted to emphasize that this is based on expert opinion and discussion. There is no Delphi survey or iterative review, and these expert opinions are not necessarily reflective of the organizations or societies that these panelists are active members of. So this was the management algorithm that we recommended. So first, we have to establish the diagnosis of nasal polyps, assess symptom severity, make sure that there's also evidence of concurrent objective findings, that the patient meets the diagnostic criteria that has been well established for chronic rhinosinusitis with nasal polyps. If they do, then as I mentioned earlier, the first line therapy is still intranasal steroid sprays, but you can also consider a short burst of oral steroids as long as it's not contraindicated. If the patient continues to have persistent symptoms despite of at least 4 weeks of medical therapy, then you can consider the next step in the algorithm, which would be repeating another burst of oral steroid or the high-dose fluticasone exhalational delivery system. So now if the patient still fails this escalation in medical therapy, in a minority of patients, surgery may be contraindicated. They may also have poorly controlled asthma despite standard therapy, or they may decline surgery. I mean, this is definitely a shared decision-making process. And if these conditions are met, then the consensus of the group was that it would be appropriate to consider a biologic like dupilumab or omalizumab. But a majority of patients, we would go ahead and do endoscopic sinus surgery. And again, there's different extent of surgeries that could be done, ranging from the least invasive, like in-office polypectomy, to a full house endoscopic sinus surgery, all the way to the draft 3, and it would just be catered according to the severity of disease. All the patients would need to have appropriate postoperative management. That would include continued medical therapy, like saline irrigation, steroid irrigations, potentially the high-dose fluticasone exhalational delivery system, or the steroid-eluting implant. Now, if the patient continues to have refractory symptoms despite appropriate sinus surgery and postoperative medical therapy, that's when we move on to the next step in the algorithm. Again, this is a shared decision-making process, and you can see that there's multiple options once you reach this stage where the patient has refractory nasal polyps to appropriate surgery and medical therapy. So at this point, you consider biologics, particularly in those patients who have concurrent type 2 comorbidities like asthma, and then assess a response in 6 months. You would also consider revision sinus surgery, so maybe a more aggressive surgery like the draft 3, as I mentioned earlier. Aspirin desensitization for patients with AERD, the steroid-eluting sinus implant, or considering another burst of oral steroids. So again, this is just a recommendation. Ultimately, I think, there's a lot of different types of patients. Every case is unique. This is really a shared decision-making process. It's personalized medicine. I always say, I don't think there's really a right or wrong answer. I think it's wonderful that we have this broad spectrum of therapeutic options. I don't consider any to be mutually exclusive. I usually present all of these options to these refractory nasal polyp patients. And usually after a careful discussion, I find that it's really individualized to a particular patient, their preferences and their unique situation. So to summarize the key points and conclusions of this chapter, CRS with nasal polyposis comprises 20% of all our CRS patients and is typically characterized by a type 2 inflammatory response. In terms of medical management, topical intranasal steroids with or without a short burst of oral steroids are considered first-line treatment. The high-dose fluticasone exhalational delivery system is an option for those patients who fail initial medical therapy, and the steroid-eluting implants are also an option in those patients who have had recurrence after prior sinus surgery. So with respect to surgical intervention, full house endoscopic sinus surgery has been recommended to remove disease in all 8 sinuses if they're present, and in order to optimize the distribution of topical therapies. There's also been some recent evidence that the draft 3 procedure reduces the risk of nasal polyp recurrence, particularly in patients with asthma and aspirin sensitivity, and in-office polypectomy with or without navigation can also be an option for patients with recurrent CRS with nasal polyposis. In terms of the biologics, dupilumab, mepolizumab, and omalizumab have been recommended as options for patients with severe CRS with nasal polyps, particularly in those who have failed appropriate medical and surgical treatments and who have comorbid type 2 inflammatory diseases. And then finally, a multidisciplinary stepwise treatment algorithm is recommended for the comprehensive management of our CRS with nasal polyp patients. So these are some suggested readings as well as the references for this chapter. They primarily consist of state-of-the-art review articles as well as the consensus statements describing the stepwise algorithm in the management of our nasal polyp patients. So again, I wanted to thank my co-editors, Dr. David Gudis and Dr. David Kennedy, for giving me the opportunity to contribute this chapter to our Enology Worldwide video textbook. I also wanted to thank you, the audience, and hope that you enjoyed this chapter that focused on the comprehensive management of chronic rhinosinusitis with nasal polyposis. Thank you.